testing for NADs is not prime time yet, and so because of that, we're evaluating clinically to get a sense of how people are doing.
You're listening to a Bio Reset Medical podcast with Dr. Cook. If you have questions or want to talk more about your symptoms and issues, you can always reach us at 650-888-7950. The following is a Q&A hosted by Dr. Cook, where he hosts weekly calls with doctors.
Okay, so today's going to be a great day. We're going to talk about, we'll go through like a nice little conversation on NAD. I got a question. It's interesting. I got a question. Like, have you had any experience of a favorable outcome with NAD/IV treating ALS? ALS is, I think, catastrophically difficult to deal with. And interestingly, like all of these neurocognitive, neurodegenerative problems, there's a spectrum of ALS patients. And so there are some that get ALS that basically it has a very aggressive course, and those patients can decompensate fairly quickly. And other people will come on more slowly, and there's a whole host of different manifestations of how it presents. And I've been working with patients with ALS for many years. I haven't found anything that I feel like is dramatically helpful. I think that there's a logic for doing NAD, and I've done NAD, and I know patients that have ALS that have done some infusions of NAD and gotten what they felt like was some benefit. I know people who've done the PK protocol. I know people who have done regenerative medicine. And my sense of ALS is that it's managing a very difficult time course. And all of the experiments that are in the category that treat ALS, I think, are experimental. And unfortunately, I don't know anyone who's really cracked the code and is making profound and meaningful changes in ALS. That being said, I still think that we still have to do everything we can to take care of those patients, but there's no great answer for that. And I think that ultimately the solution to that is going to be like the solution to many of these things. We were talking about MS last week, and I think it's that there's going to be a case to be made for peptides, for regenerative medicine, for a functional medicine approach that is underlying it to try to assess, once again, are any of the obvious things that we've talked about, mold, infection, Lyme disease, are any of those things present or not present? If they're not, then great, we don't have to worry about that. If they are, then we have to start our way through kind of a logical process of dealing with that. And so, with that in mind, I think that there are many modalities that may be helpful, but I think it's also important to not meet somebody with a new diagnosis of ALS and then to give them the impression that, this is probably going to be really helpful for you and cure things, because a lot of times I find that people are have been maybe maybe had more hope for a therapy to be transformative than it had to be, and I think that ALS is the most difficult condition to treat that I'm aware of. So with with that in mind, that's kind of my thought on that. And if you wanted me to talk more about ALS, I'd be happy to do that.
Just put a question in your chat box, Dr. Cook. It was just submitted.
I have not.
So do you want to read the question?
Have you used NAD to treat mal de Querment syndrome? I have not treated that condition. So then it's interesting. So NAD is this interesting molecule. I think of it as a signaling molecule, and it's a signaling molecule that relates to our energy stores in our body. And so as long as our NAD levels are high, it's a signal that energy stores are good. I kind of like to say that economic indicators are good. And if energy is good, then that means we can do things. And so if NAD is high, we tend to drive DNA repair. We tend to drive detox pathways. And it's a driver for oxidative phosphorylation in the mitochondria. And then it drives physiological processes in the cell. And there are, when we went to medical school, we haven't had a good test, and we still don't have a good test for NAD levels, partly because it's quite unstable. And so if you want to test NAD levels in plasma, what happens is in the current algorithm, what people do is they stick a needle, draw blood, put that blood in a cooled centrifuge. And so the cooled centrifuge, and I actually have one of these just because I have been wanting to get into doing this. And I'm still not doing it, and I'll tell you why I'm not doing it. But basically, you put it into the cooled centrifuge, spin it, get the plasma, and then freeze it. And then the logic is that they take that frozen plasma and then take a whole bunch of samples, and then they run them together to test. My understanding from talking to the PhDs that I work with is that they have very good within a test validation, but then test to test level, they've been having challenges in validation. And the testing for NAD levels has been done by research labs, but there have been challenges because of the low stability of it in reproducing levels, and so that we're clinically assessing how people are, and then based upon that, when to use NAD. So the testing is basically, the moral of the story is the testing for NAD is not prime time yet, and so because of that, we're evaluating clinically to get a sense of how people are doing. And so then it's great because this week is a great week because this is kind of an addiction week for us. And so I've got a number of people who have had addiction issues for quite some time who are here, and we're running them through our protocol. So remember I said NAD is this signaling molecule. As long as the levels are high, the concept is that we can do all the things we need to do. We can run our detox pathways and make energy and repair our DNA and do what we have to do. What happens is if someone has been drinking very large amounts of alcohol, then there's the theory is that 2 molecules of NAD are lost for every molecule of alcohol that's broken down by alcohol dehydrogenase. So alcohol dehydrogenase, breaking down alcohol is a metabolically expensive project in the body. And so since it's a metabolically expensive project, we need to donate energy to facilitate that reaction. And NAD donates that energy. But then what happens is then some of that NAD that is in the NAD stores that was going to be used to make more energy ends up being utilized to break down alcohol. And that's also the case with opioids. And so then what we will do is we will do a 10-day protocol where we do an infusion every day for 10 days, taking the weekend off. So we do a Monday to Friday, take a couple of days off, and then do a Monday to Friday rotation again, where we're giving NAD every day. Now, the experience is quite interesting with alcohol. I think is potentially one of the better experiences with NAD that exists on the planet, I think. And that's because as you start to give people the NAD, typically somewhere between day 1 and day 3 or 4, all of a sudden people kind of like wake up and then start to interact more, and people are like, oh my God, I feel like I'm alive again. It's really super interesting. And what people will tell me is the cravings start to go down. And so it's been a super great experience for us. Remember I said that you can do NAD sub-Q, you can do it IV, you can do creams that you can rub on, you can do patches, and so then there's and then you can do the nasal spray. The issue is for the addiction space, and there's been more of a history and more of a long-term use with NAD in addiction than in any other space in medicine. And so we do the IV form in addiction, and the reason is because we're pushing to get to a dose that is high enough. And so then what dose am I talking about? I'm on addiction, I'm gonna try to get to 750 to 1,000 milligrams a day. If somebody has an extensive and long-term history of addiction. So then you say, how long does that take? And it's interesting, it takes somewhere between 3 and 6 or 8 to 10 hours. I still remember and what happens when you give NAD IV, people get a flushing and a histamine reaction. And interestingly, I think that there's a component of the flushing that relates to your methyl status, and I'm going to explain that in a second. But there's a component that also relates to your detox status. And so then in my old life, which was super interesting, I was an anesthesiologist, and so I was breathing inhalational anesthetics like every day for quite a bit, because every time you take a patient to the recovery room, they're breathing sevoflurane on you the whole time. It was super interesting. But so I remember I was kind of worried about the money myself because I didn't have any money. And so I said, well, let's do this. Let's do NAD. And I still remember it to this day because I put an IV in and I gave it to myself, and I put 1,000 milligrams in the bag, and I said, let's do this. And it was like 3 o'clock in the afternoon, and I finished that IV at about 2:30 in the morning. And so then what that shows you is that I think I was fairly toxic, and my methyl status was probably not that good because that was a long time ago and I hadn't done a lot of this stuff. And so if I sped it up, I got overwhelmingly intense histamine type of reaction. And that histamine reaction, sometimes people feel it in the heart, Sometimes they feel it in the diaphragm. Sometimes they feel it in the abdomen. And then sometimes they feel it in the pelvis. If they're walking around, you'll feel it in their muscles. And then sometimes people can feel it in their head. And then almost every time when somebody does the IV, you'll feel it in your sinus. And when you feel it in your sinus, you'll often sneeze a couple times, and then that will go away after about 15 minutes. But some people will have sinus congestion and symptoms for maybe like the whole length of the IV that day. Any of those feelings will almost immediately, within 5 minutes, go away once you stop the IV. The reason I say all of this is because it's useful to memorize and know all of those symptoms if you're treating someone, just so that you can talk your way through and help talk people through those symptoms. I did this podcast with Joe Mercola, and as part of doing the podcast, it was awesome. He sent me a podcast that he had done like the day before, because he was doing this mitochondrial thing with Dr. Sinclair from Harvard, who's a total genius, and I super respect him. And I don't know him, but I do want to talk to him as soon as I can. But I was listening to him, and he was talking about the methyl cycle, and he was talking about the fact that he takes fairly significant doses of his supplements, but then when he looked at the methyl cycle, he realized that as you shuttle through the methyl cycle and through the NAD salvage pathway, having methyl donors is helpful. And so then I looked at all of that, and then I realized, I wonder what would happen if you gave someone methyl support when they did the NAD IV. And so then I started giving people trimethylglycine, and that was just kind of a wild shot in the dark, just because it's it's a methyl donor that I think is the most easily tolerated methyl donor that doesn't seem to have much in the way of side effects. And so I started giving people trimethylglycine before NAD IVs, and what I found is that the severity of the flushing reactions that people get when they do an NAD IV went down by more than 50%. For some people, it totally went away, and other people still had some flushing. And so then that's an interesting data point. What's happened is I've done just, whatever field you're in, you're going to do a lot of. So if you're a plastic surgeon, they all have like way too much plastic surgery. So I've probably given myself too much NAD. I joke, but then I'm going to tell you my thoughts about that as well. But interestingly, as time went on and I did it more, what happens is that flushing reaction seems to kind of fade. And so on a scale from 1 to 10 of getting flushing with NAD now, to me, it's like a 1. Like I kind of barely feel it. And I've generally noticed that over time, that people have less symptoms. And I've also noticed over time that a lot of the people that I have seen for some time do better and better and better, and they don't need as much of it. And I'll kind of talk you through that part. And interestingly, I feel that flushing has a vascular component, because when you feel it in your chest, it's almost like you feel it in your heart. And then whatever the issue that people present with when they come to see you often gets exacerbated while you're doing an IV. So for example, we had been having this conversation about like just what I just said. And then I started to get some people with endometriosis, and then they would feel the NAD flushing in the area where they would feel endometriosis pain. And so then that's just an interesting sort of idea to be aware of. Somebody texted in, Ken texted in, would an antihistamine help? That's a great idea. We should test that. I haven't tested that, but we've just done this methyl support. That's a really, really very good idea. So good job. I'll test that tomorrow. So then other things, it's interesting, if you do an IV ozone treatment, it turns out that the flushing that you get with NAD is also about half. And so a lot of people, if you give them IV ozone and you give them the methyl support, they get the NAD and they like barely feel anything. Someone asked a question of what can you combine with IV in terms of IVs? And so since we're on the topic of ozone, I often will combine NAD and ozone together because I think that they're quite synergistic. And one of the major philosophies that Dr. Schallenberger puts forth is that NAD facilitates these oxidation reduction reactions, and NAD and ozone will donate an electron and convert NADH back into NAD+. And so the idea is that ozone increases your NAD levels intracellularly. And that's because that electron gets shuttled into the cell, either by a lipid peroxide that was created when O3 combined with a lipid, or the O3 dissolves into the cell and then converts NADH into NAD+. And so his idea is that it increases the NAD plus to NADH ratio, which intracellularly, the goal is for that ratio to be 700 to 1. Now, this is a hypothetical number that's based on some of the basic science, but I think that's the best information going that we have right now. What I can tell you is I've had 40 or 50 people who I did IV ozone for, and I gave them NAD, and they felt like they'd had like 10 cups of coffee. In general, people just feel really good and feel like they have a sense of energy. But some people, basically the NAD is driving energy, and then the ozone is driving energy, and then together they have this very synergistic effect. How do you manage that? And then how I manage that basically is sort of this similar conversation to what we do all the time, which is start low, go slow. This very Schallenberger-esque. Take your time and then do one or two things at a time, and not give everything at the same time. And so the question somebody wrote is, it doesn't make sense as O3 is an oxidant. So O3 is an oxidant. What happens is in the body, it donates an electron. When it donates an electron, so it has an oxidant effect on the body. The body responds by having an antioxidant response to the O3. But when it donates its electron, that electron does something. And the theory is that when it donates that electron, it converts NADH back to NAD+. So that's the concept. So then our worldview on NAD was informed and comes from the experience of the addiction world. And so then within that space, people would do a 10-day protocol, and Dr. Medier, who's down kind of near New Orleans, has been doing NAD IVs for people for, I think, 15 years or so, and I'm super grateful to him and to the work that he has done, and I have spoken to many people that he has treated, and he has really helped to inform and shape the educational experience for people who in the space. And I think it's been really, really wonderful, his contribution to science in this regard. the experience that they had there, and I got this from talking to him and his wife, who's also great. And the experience was that they would do the NAD/IV, and a lot of times what would happen is in the addiction side, and they would do the 10-day period, and they said people would do great, but then all of a sudden it was like they went up a cliff, and 2 months later or 3 months later or 6 months later, it would be like they never happened. And then they would come back into their clinic and they would do an NAD/IV. And then generally in 1 or 2 days, they would get back to where they had been at 10 days. And so when I first learned about NAD, the idea was, well, just do the 10-day protocol for addiction and then see how they do. And then whenever things start to get a little sketchy, then just have them come in for a booster. And the idea would be, if they came in for a booster in 3 months, then what you would do is then have them come back another 3 months for their booster. What we evolved into doing is we evolved into doing a 10-day protocol and then doing boosters sooner to try to prevent people from having problems. And what I immediately started doing is doing subcutaneous NAD, where you take a vial. And so the NAD that comes in the subcutaneous form is 200 milligrams per mil. And so remember, on the IV side, on the addiction side, we're trying to get to 750 milligrams. And so 200 milligrams is a lot less than 750 milligrams. And so, but still, you don't have to have an IV, and it's super easy, and it takes about 10 seconds to do. So that's, I think, positive and a good experience. And so we started doing this, and I've got about 4 or 5 different algorithms that I use for the subcutaneous NAD and addiction. And for a lot of people, when they leave here after the 10-day protocol, I'll have them do one sub-Q a week. And so then they're just doing a treatment once a week. I'll have some people who will do it a couple times a week. And then for people who've had fairly sustained addiction things that have been going on, I will have them do it 3 or 4 or 5 days a week for the first month to just kind of get them through that moment. It's a lot of NAD on the one hand, but on the other hand, what I found is if I'm willing to escalate up my frequency of dosing in that first month, I feel that I keep symptoms and cravings low. And when I do that, it's like I talked to one guy, I had this really nice conversation with him, and he was like, I'm doing great. I'm talking to my sober living person, but he goes, if I'm honest with you, I'm still trying to figure out every single day how I can sneak out and get a drink. And I think that the biochemistry of resetting with the NAD is super helpful on that front. When people come in for that, I will often do some ozone combined with it, and out of that 10 days, I might do that two or 3 times, but I won't do that every day because I don't want to do too much ozone. And but I do find that that's very helpful in the addiction space. I will generally give vitamin C, B complex, B12, and magnesium every single day that they do their addiction IVs. And I find that when I do that, people do better. So I'm giving an antioxidant, I'm giving magnesium. Everybody generally feels better with magnesium. It relaxes the blood vessels. A lot of these people have headaches, and a lot of times the magnesium will help with that. And it relaxes the blood vessels. And I've noticed that when I do that, that also makes NAD go better than if I don't give the vitamin C and all that stuff together. And so 100% of the time I bundle in all of those IVs with the NAD, and I don't charge any more for it. The next thing is that glutathione is a great antioxidant for patients with liver issues. Glutathione is an important antioxidant in the liver, and I have noticed that it can be extremely helpful for many patients. I've also noticed that some patients can have quite a bit of trouble with glutathione, and sometimes I think that's because they can't deal with sulfur compounds, and when that happens, that can be a challenge. Sometimes people are low in molybdenum, and so we have molybdenum, and if we give glutathione, a lot of times people will we'll give them some sublingual molybdenum, and they'll absorb that, and then those symptoms will go away. And so then, obviously, I evolved to every time we give people IV glutathione, then I give them the sublingual molybdenum before we give it to them. Now, then the next thing on detox, and it's interesting. NAD can trigger detox. And then the other thing that can trigger detox reactions is glutathione. So I had one person who just about I felt like was going to code on me when I gave them glutathione, and it's interesting because the traditional conversation, and I think it was before people basically knew how to use angiotests, is that they would put a butterfly needle in and then do a Myers cocktail push, and then they would do a push of glutathione. And I super strongly recommend that nobody does that, primarily because I have like 20 or 30 people who I just super love as patients that got IVs where they got that genre of IV, and it led to a bunch of basically like thickening and clotting of their veins, and so that all of their veins are totally scarred up. If you make isotonic solutions of vitamin C and these things, and I can coach you in how to do that, but that never happens. And so I think that that's like a crucial thing to be aware of. The next thing is that glutathione is interesting. It can cause a hell of a detox reaction. And if I go back to myself, I remember the next thing I learned about glutathione, I was like, let's do this. And I gave it to myself, and I thought I was going to die. It was crazy. And so then I had to back way off and start to give myself super low doses of glutathione. And so I would give and so glutathione is also 200 milligrams per mil. And so if somebody walks in and it seems like they don't have any problems, then what I do is I give 3 cc's of glutathione, which is 600 milligrams, which is kind of a standard dose. And then I will ask the nurses to hang that and drip it really slow for like 15 minutes. And so what I'm getting out of that, and Virginia Osborne is one of my mentors who I found to be very influential, and she teaches IV therapy courses. And I think her and Dr. Anderson are probably two of the smartest IV therapy educators in the world today. And I give them by far my highest recommendation. And it is interesting because even they talked about, I went just to see what was happening to one of their courses, and right away they said, oh yeah, we used to always do IV glutathione as pushes, but now we always put it in a 100 cc bag, and we've noticed people do a lot better with that. So these are little pearls that I don't know if they're helpful, but I wish that somebody would have told me a bunch of this stuff 5 years ago. So then so then to answer the question on NAD, 100% of the time when I give NAD, I will do combinations of vitamin C and magnesium and B complex as one thing, and then follow that up with NAD. You can combine, and they seem to combine very well, B vitamins and magnesium and vitamin C. Glutathione doesn't like to be combined with those, so I never do glutathione in the same bag as those other things, and I always do glutathione last. And then NAD is unstable, and so we never do glutathione with all of those things either. That being said, I've talked to Virginia, and I've talked to some of these people. And they'll say, "Oh, if sometimes we'll just put maybe half a cc or 1 cc, i.e., like let's say 50 or 100 or 200 milligrams in like a Myers cocktail bag." There are some people who do that. The teaching from Dr. Madier is strongly to not do that, and so I have not done that. But I know that there are some people who will combine the NAD with other vitamins. But my experience has been to keep it separate, and I've done very well, and that's been my practice, is to keep them separated, and then sort of to thematically work our way through that. The one knock on NAD is that it may drive senescence, cellular senescence, which is cells that are taking up space in our body, but have become dysfunctional or not doing something. My analogy is they're taking up a room in the office, but they're not participating. And so then there is an idea of, if you're going to do NAD, then to combine something that is a senolytic with that. And so then my favorite thing in that category is quercetin. And so we'll always combine quercetin with NAD. And if you're doing that orally, I think you can probably go up to very easily a gram, but even potentially you can go to high dose, particularly if you're not doing NAD that frequently. Maybe 1 or 2 grams. And we've had a good experience with that. And our experience is that when you combine quercetin with NAD, people generally will feel better. And I think it's just a more harmonious way to do it. And then we've got a bunch of different things that we do. If I do it, if I have it around, and which I usually do, we have Sammy. And if you take Sammy with NAD, it makes either the Sammy works better or the NAD works better. I think they're both working better. Sammy is part of that methyl cycle you're driving. And if you take the TMG and Sammy and NAD, that's probably the most energy that I've ever felt in my life. So that was, I felt like an incredible amount of energy when I did that. Now, that being said, people who are fragile, whose energy pathways are not fully dialed in, you don't want to give them that charge because they probably can't handle, and a lot of times they'll feel a little shaky and fragile with that. Whereas if you've kind of worked everything out, probably it's going to be fine. Another thing is, interestingly, when you inject the NAD sub-Q, it can burn. And then some patients, 10%, 5%, will have a fairly significant detox reaction when they inject NAD sub-Q, but they'll be totally fine when you give NAD IV. And I have a theory that those patients are somehow inflammatory in their fat, and their fat's a little toxic. And I haven't really noticed it to be related to actually how big they are. And so I've seen some people who are pretty skinny, and then I'll do or normal, and we'll do the NAD sub-Q, and then they'll have this real detox reaction, or they'll have a lot of pain at the injection site. It turns out, I think I was one of those people. When I did NAD sub-Q at the beginning, I thought, I have made it to the promised land. This is going to be the greatest NAD sub-Q. And I did it, and I was like really uncomfortable for like 4 or 5 hours every time I did it. And then I think I did it about 20 or 30 times, and then next thing you know, it went away. And so now it doesn't feel like anything. Now, as I was saying, but what I've noticed also is that when you start to do the NAD sub-Q, it seems to reset these energy pathways. And then once you've done it a while, I notice you don't really need to do it anymore. And so the only time I do it is if we have like expired vials, and then I just will use them up. And then it's kind of interesting for me to experiment around with that. What my idea is that if you're going to do it, I like to use NAD to drive some physiological processes. And I'm thinking, I'm trying to think, who am I dealing with and what am I dealing with him? Am I dealing on an infection path, a detox, a wellness, an addiction? So I'm kind of looking into what's happening with those people, and I'm trying to drive that and then step back and then try something else. And so then one thing that we've played around with on the peptide side is doing NAD and then taking a break from that and doing 5-amino-1-MQ, and then taking a break from that and then going back to NAD, so cycling through that pathway. I've talked to Dr. Seeds in some detail, who I think is the smartest person on peptides that's on the planet right now, like kind of like by far, which is awesome to talk to him. And so then he's a little bit against NAD because he's trying, and I think, well, I'm going to have him on the podcast, and we're going to go through that conversation back and forth, which I think is going to be really good. So he's using more of the peptides, but even when he's driving the mitochondria with peptides, he's doing that and then stopping. And so I think that this is a crucial fact to consider, and we're putting this up. And so I'm rehashing some concepts that I may have mentioned to you before, but they're probably worth hearing again. But that means I'm not suggesting that NAD is this energy panacea that you might do for 5 years in a row. To me, it's an idea that I'm using to kind of try to restart a detox pathway, for example, and then or an energy pathway, and then I'll do that and then step back and stop, or then I'll stop it and then try to do something else, and then try to get things going and then see how they do. Basically, what I almost always find is that the frequency that people need to do it starts to go down because people start to get more energy and feel better. And so then that's I think, a quite positive experience. The question about the sub-Q also is, you have to think about, if I was doing an IV, then what's happening is it's dripping in, and I can see the drip rate. If I get too much of a histamine reaction, then I just turn the IV off, and that reaction, whatever it is, will start to go away in like 30 to 60 seconds. If you do, I'm not sure who's unmuted. Thanks. If you do the sub-Q, you're committed to whatever you've put in. And so I kind of quickly try to get a sense of where people are, and I will have people start with 50 milligrams, and almost nobody flares with that. Then I'll have them work their way up to 100 to 150 to 200. And the sweet spot where most people feel the best is somewhere between 100 and 150 milligrams. For people who are on the addiction side that find that NAD is really helpful for them, I have people where that will do 200 milligrams and wait 2 or 3 hours, and then do another 200 milligrams on the other side of their abdomen. And so then they've gotten 400 milligrams. And what that does is that just keeps them at a dose where they've got enough, they're getting some number that's close to what they would have gotten if they gotten an IV. And so this has been a good experience for me, because obviously, like I have some people that I just saw who basically, it's hard to come in every day for the detox protocol, yet they're dealing with addiction, but they're also trying to go to work. And so then we're using this as a 10-day protocol, but then if they can't come in, we'll give them sub-Q NAD and have them do that on the days when they can't come in. For the addiction protocol, I think the update that's kind of interesting is to then think about peptides, because I think we've had a really positive experience working with and supporting patients with peptides in this experience. And in broad terms, what I'll say is I try to get a sense of, is there a major immune infection problem or not? If there is, then a lot of times we will get people taking thymosin alpha-1, and I'll find that really starts to modulate and calm down the immune system, and then we'll use that to support people while they're going through the protocol. If they're more in a pain, just kind of difficult situation, often we'll use thymosin beta-4 and BPC 157. And we'll also, depending on what's going on GI-wise, often give them oral BPC 157 through that. So then I got from Billy, in my self-experimentation of N equals 1, I found the histamines did not help me. And I've talked to a whole bunch of people who told me that the histamines didn't really help them, but the antihistamine medications, but that the methyl donors did. And so that's why I talked to so many people that told me that you didn't get any benefit from taking antihistamines, that I've just never tried it. What I can tell you is that there are some people who take Sammy and it's the greatest thing that ever happened to them. And then there's another group of people that take Sammy and they do not feel good, and it sort of is too much, and it's too much of a driver. And so, and then like I told you, I've never done cocaine, but when I did NAD and Sammy and TMG, I felt like I must have done something. It was crazy. And so that being said, be super careful with the Sammy as you support people going through that. We've mentioned this, but just since this is kind of a good little NAD thing, remember that people with Lyme and chronic infections and mold, often NAD will try to drive detox pathways. And I think this may be especially true with mold. Some of those people can get really sick and start to decompensate if you give them too much NAD. And 200 milligrams of NAD is often too much in that population. So then you begin to see there's this a trimodal response, which is the addiction people, the Lyme and complex illness and mold people, and then the wellness people in the middle. Wellness people in the middle, generally, you can kind of do whatever you want. Addiction people, you can almost do whatever you want unless they're addiction and super sick. But usually they're not super sick if they were recently drinking much, unless they hit the end of the road and it was kind of a crash landing. For the wellness front, a lot of times we'll have people do 2 or 3 days. A lot of times I'll have people do 1 or 2 days of IVs before a big injection. And I've had a great experience with that. A lot of times I'll have people who will say, oh, I've been in this chronic viral mold kind of just dysfunctional episode in my life, and with brain fog and difficulty concentration and difficulty getting stuff like that done, work done. A friend of mine, Martin from Upgrade Labs, I think it was him, came up with the idea for a name of the sub-Q injection, and he called it the best day ever. That was what they called that IV at Upgrade Labs. And so it kind of is the best day ever. And I have had a ton of people whose lives were just not happening and it wasn't working, and we got them to do a little bit of sub-Q NAD, and it really boosted things and kind of brought things back online. And then that success was enough to begin to let everything else work. And that is, I think, a good way to think about it. It's a rebooting kind of strategy, but it's not a permanent and super long term. And then I'm actively and continuously looking for other things to cycle in as modules and alternatives to it, so that you build this robust approach to helping people cycle through with energy. I got a question about, can you do NAD with vitamin C? So the answer, yes. Now, what we will do is give people a fairly significant dose of vitamin C, 5 or 10 grams. And then after we do that, then they'll move through the NAD experience, and I've done that thousands and thousands of times with good results. With good results. So then that's been positive.
BioReset Medical is a medical practice specializing in integrative therapies and advanced wellness protocols. At BioReset Medical, we treat some of the most challenging to diagnose and difficult to live with ailments that people suffer from today, including Lyme disease, chronic pain, PTSD, and mycotoxin illness. Our team has a wealth of experience in advanced integrative strategies to get you to optimum wellness, many of which can be conducted remotely from the comfort of your own home right now. Our team's approach is to use the most non-invasive, natural, and integrative ways possible. Find out how we can help you by reaching out to us at 650-888-7950 or at our website, www.bioresetmedical.com. It's going to be amazing.
So then there's a question, apparently somebody said the Medier said 250 milligrams each day in 2 days is better than 500 milligrams in 1 day. And then he says to mix a 500 milligram, 500 cc bag and refrigerate half of it for the next day. So I would never do that. So I don't know. Here's the thing. We had all of these rules that just came from like the experience in the hospital. And so then, so anytime anything was spiked, the sun couldn't rise and set on that product. And so it's kind of like you can't let the sun rise and set on a bowel obstruction. And so if there's anything in my office right now that's open, there's a 100% chance that that's going to be thrown away at the end of the day. I don't care what it is. And so then that is just my approach. If you have a vial from Archway, I'm fine with just taking half of it up and then putting it in a bag and then taking the other half the next day. I think that's reasonable. But I never will make a bag and let that bag sit overnight. And then that's just comes from the sort of sterility rules that come from a hospital, and I guess I just still follow those rules. And it may be that if you told me that there are an organization that said that would be okay, that would be fine, but I still probably wouldn't do it. And I just kind of obsess about sterility more than kind of anybody that I've met up until now in this space, just because I came from a world of a lot of sterility. And so I try to bring that here, because I think that the more that we do to promote sterility and lack of complications, I think the better. The question is NMN or NR. Is that helpful before, after? So Chris Shade of all of the geniuses about NAD in the world, maybe is the top. He may be like, I super love, there's almost nobody I would rather listen to than him, like 24 hours a day. He's just totally the greatest. And I have considered him a mentor for many, many years. He makes a product that has NMN that is driving the methyl cycle, and he put TMG in it, I think, intelligently. And I love that product. And what I can tell you is that it's a sublingual pump, and I have it in my office, and then I have it at my house. And this is just me. Whenever I remember to do it, I do it, which means that I do it about 3 days a week. But when I do it, I feel I feel like it does something. Like I feel more energy, and I feel really good with no side effects whatsoever. And so I think that his product, and I think that product is by far the best NAD energy product that there is, and I feel it. Now, I like the concept of NR. Like I definitely like the concept of it. And if you gave it to me for free, I would definitely take it. I've probably talked to like 800 people who told me that they take it, but they always say, I take it, but I don't feel anything. And so what I would like to do is to try to dig into physiologically, how much of a benefit do you get from that? And then how is that affecting things? That is a terrible answer. I'm going to judge myself. But what I can tell you is I feel like the NAD Gold, the NMN, you feel good, and you tend to feel more energy. And I haven't had that experience with the NR, but I do still feel like scientifically it makes a lot of sense. I think it makes a ton of sense. And so we just have to, and what I want to do is, interestingly, then start to dig into people who have low NAD and see how helpful that was. Let me give you an example. What about addiction? I bet you that if you do NR, NMN, and things in that category, you're going to drive the salvage cycle, drive up more optimal use of NAD, and that may help prevent recidivism with addiction, which would be totally fantastic. And so what am I doing now? Everybody that comes in that's on the addiction side, I'm starting them on NMN during the treatment, and then I'm keeping that going. And they're just kind of staying on that permanently for a year. I talked to somebody, I was like, how many times have you I talked to somebody recently, and I said, oh, how many times have you relapsed in the last 6 months? And it was like 3 times. And apparently the data is that it's the average is 7 times, which is fairly intense concept when you think about how what an overwhelmingly stressful thing it is to fall off the wagon and all of the social and life consequences of that. Now, to go down the addiction road a little bit more, then interestingly, what else can you do to support people? And so just about everybody that comes in on the addiction side, we're doing a ketamine treatment because it helps to reset your neurotransmitters, and it drives turning off NMDA pathways, which may be associated with depression. People tell me, oh, I feel way less depressed when I'm doing ketamine. And so we will do a little bit of ketamine during that 2-week period. And then 95% of the time, I'm also doing a stellate ganglion block and resetting the experience of fight or flight and stress. And it's interesting when you think about addiction. Is I talked to somebody I did a stellate ganglion block for yesterday, and the question was what caused everything, and what caused everything was mom and dad were horrible alcoholics, and so then there's no boundaries and there's sort of emotional chaos in the house, and so there's no ability to kind of just get a sense of a way to get your grounding in terms of just building relationships and having kind of a normal life. So then that's super helpful. We've done a lot of work with neurofeedback, and I think that's a great tool to use in that space. Now, real quick before I go on, is there any questions about NAD? Did I leave anything untouched about that? Trying to think if I missed anything.
Dr. Cook, you might want to mention that we're hoping to open up our NAD certification class this summer, at the end of the summer in August.
Oh yeah, so we're doing the certification course for Archway, and I did a course which was super fun, and then we did IVs on each other, and we did sub-Q injections, and kind of got an opportunity to kind of learn all of this stuff. And I think I even had a couple non-practitioner patients who showed up to that class, and so we're hopefully, and the whole world went to hell with COVID, obviously, and so that was a challenge, and so we're getting back to the idea of starting to open up our clinic's fully open, but we're getting back to the idea of running some courses, and I think we're going to try to do something in August. And so if we do, Kristen will post it, and we'll try to do a NAD course soon. Now then this is an interesting one. this is a super interesting one. Dr. Medier told me, and I vividly and viscerally remember him telling me this, and I think it maybe is because my father's a psychologist, and so I grew up in a psychologist family. And what he told me is, and Dr. Medier is a psychiatrist who does NAD, and so he does all of these IVs. And he told me that there's no psychiatric condition that he has seen that didn't get benefit from NAD. That's a big statement. Now, what I have to say is that's what I've seen. So I have treated very peripherally, but like I had someone have a psychotic break and their family brought them in and I gave them NAD and they got like way better. I've treated lots and lots and lots of people with anxiety and depression. And I think that NAD is not a panacea or a be-all, end-all, but I've found it to be very helpful in those groups. I have found, remember we were talking about the addiction experience and that we're doing ketamine. We see a lot of people with PTSD, and if you just kind of like dive into the NAD community, a lot of people who are in the NAD community will take care of patients with PTSD. And my experience in talking to them is that they have a very, very good experience. And the reason I think that is that if you're driving improved mitochondrial function and then you're driving improved detoxification, then there's going to be improved clarity of consciousness and thinking and cognitive processing as a result. And as that happens, people tend to feel better. And this is kind of my theory on that. But we've had a very good experience helping people within the psychiatric, psychological space. And I think that I would rather like walk 1,000 miles. I would rather walk like 10,000 miles than take an antidepressant, I've got to say. Like, and this one is an interesting one. There's a lot of interesting pharmacogenomics around how people respond to antidepressants. And I remember learning in medical school about antidepressants, and it just seemed like it was not that big of a deal. And, you put people on all these medications. And what I can tell you is that I've got 30 or 40 people that I have seen who came in on antidepressants, especially nortriptyline, sometimes on the serotonin drugs, and they've had a harder time getting off that than the worst opioid addict that I've ever seen in my life. And so I'm, just because I don't see them very often, I haven't totally perfected an approach and figured out exactly what to do. And because it's such an important physiological process, I think that what's going to happen is you're going to need to work in a whole bunch of categories to basically reset those people. And so you're going to be doing peptides that have central nervous system effects, combined with a lot of these other things. But I've generally found to be NAD quite helpful and supportive to those patients. And then in general, broadly to the depression, anxiety, PTSD patients. And so that and helping, I've got to say, helping those people is honestly totally one of the highlights of my life. And we've treated a lot of people, a lot of therapists, a lot of psychologists will come and find us. And it's just like totally a pleasure to help them, because I think of them as kind of like first responders in a way, helping people out in the field. And especially at this moment, with everything that's going on and culturally in our society, is kind of which I'm just going to go on the record and say I kind of think it's great, because we needed change. And so I'm really standing for that something amazing is going to happen, that's going to be good, and that we're going to have a culture that's more supportive of everybody, and that it's going to be better. That's like, I'm going on record as saying that. That's my prayer. So then somebody made a comment about microdosing mushrooms. Interesting concept. I've heard a lot of people come and talk to me about this, and I see a lot of people. And with people if people microdose and they do subcutaneous NAD in the same day, they tell me that they feel better and that the microdose works better. Also, what happens is you break down any substance you take. You will feel better when you take it, but it will also wear off quicker. And then if you take NAD the day after any substance, hangover feelings are less, and people feel better and just have less side effects. So that is a intriguing and interesting sort of area, and that's sort of, I guess you could say, ridiculously and wildly off-label on the one hand, and yet I think there's going to be a experience where all of that is coming to a theater near you soon, because I think, what I'm hearing is that psilocybin may be legal like in the next year. And there's these people in San Francisco that are doing MDMA, also known as ecstasy. And I was at this meeting. It was great, and I'll kind of finish on this, but this is a good one. I was at this meeting, and so and obviously these are addiction people, and so it's hilarious to me. I'm going to every meeting, or I'm at least going to every community, because I want to know what the hardcore addiction people think, and I want to know what the hardcore NAD people think. So then they were talking about MDMA, and apparently the people figured out right away when they started having people do MDMA that what it did is it gave you a fairly profound feeling of empathy. But then they were like, that's a terrible name for a drug, so we got to get a better name for this drug. And so we're like, well, what are we going to call it? And so they're like, oh, okay, we're going to call it ecstasy. And so it's a better name for a drug. And so then that was how MDMA got its name. And as you kind of come into this space, it's very useful and I think informative to have an experience of talking to people, because I can't tell you how much I learn from patients. And I had a patient last week that I did a stellate ganglion block for, and he was like, yeah, I've been in fight or flight forever. And then I was like, well, what's been happening? Has anything helped? And he goes, I did a guided MDMA journey, and it was the best thing that ever happened to me in my life. And so I was like, wow. And somebody says that to me essentially every week. like one person will say that to me every single week. And so it's been a very interesting experience for me to kind of contextualize and think about that. And I'm in some level of communication with the MAPS people who are doing a clinical trial and working with a lot of people in this space. And how I and then so since you brought this up, then I'm going to try to put together my worldview of how I think to think about these things in a functional way. So when we're, and then I'll end with this, but I do think this is kind of sweet. So when we're kids, we have a fairly pure expression and sense of empathy. And so I really get this from my nephews. Like when I'm around my nephews, they are just like pure, the purest expression of love that I've seen up until now on the planet. It's amazing. And so, so then the empathy is amazing because it's like, oh, hi, how are you? I remember how I felt when I met my first friend, Lee Beckner. And I said, hey, do you want to be friends? And then we were like friends for 15 years. It was amazing. And so then there's that. The psilocybin and LSD are thought of in their communities as sort of consciousness openers. And so then what happens is people who are working with those substances are working kind of on opening consciousness with the idea of seeing potential and possibility in their life. The often people who are using those substances will use the MDMA, which is considered to be a heart opener, to kind of open up, and then they'll do that as a combination. And I'm not promoting or encouraging you in any way, shape, or form to do this. I'm just letting you know that this is out there and that people are doing that. And so then what will happen is many people will then do NAD to start to improve metabolic functioning before they do those. And when they do that, typically they will have a lot less side effects and feel better afterwards. It's fair. What I think happens is in trauma, often that there's that moment when you feel the pure acceptance and that naive, childish, oh, we're going to be friends forever, kind of like that Beatles song, I'm in love for the first time and don't you know it's going to last. And then all of a sudden it's like, oh, it may be that it was sarcastic that they said, don't you know it's going to last? Because it's like, ah. And so then when it doesn't last, then it's like your heart's broken. And then all of a sudden we swing from empathy to no empathy. Now, obviously that happens to all of us. And that's a normal experience. But when that happens continuously from the time that you were 1 or 2 years old, because you're in a chaotically dysfunctional family, often those people were never taught or learned how to have any kind of normal relationship and then any normal patterning of boundaries. And so we don't do anything like that here, and we're not going to be one of the clinics that does that. But there are a whole bunch of clinics that are gearing up to participate in the MDMA clinical trials. And then a lot of them will end up coming here, both for stellate ganglion blocks and ketamine. What I always tell people is ketamine is a very good thing to do before, because it is a self-limited, very low side effect 30 to 60-minute intervention that can be done at a microdose. And so what happens is if you can start a process of journeying into self-acceptance that leads to emotional connection with other people, and then you can begin to see that your relationship and your place in the world, and that everything is going to be okay. What my attitude is, ketamine is legal and safe, and so that's just the best thing to do. And if at some point in the future these other things become legal, then so be it. But at this time, I try to encourage people that there are some great legal strategies. When people take matters into their own hands, I tend to be very non-judgmental and just supportive. And but I found it to be fairly useful to physiologically kind of understand this stuff, because a lot of people are out there doing it. And part of that is I think that people have been somewhat abandoned, in my mind, in the space of PTSD, just because we haven't had any good solutions, and it's been difficult experience for patients. I remember people told me they never get better, so don't do it. And so now, as we kind of get into this experience, I think that it's incredibly helpful. And so so I'm very, very positive about it. I'm looking at this note. So that's just a private note, sorry. That being said, you have all of these ways to think about kind of PTSD. Part of it is seeing, part of that is the empathy, part of that is your mitochondria working. What I feel like is you don't really, once you get really good at it, I kind of feel like, and this is my interesting idea on addiction and stuff like this, I just basically feel amazing now. And so I don't feel like a desire to medicate. Whereas I remember in the past I did, especially when anesthesia is extraordinarily stressful. And so what I feel like is once, and this is my idea, once you get, it's kind of like the 99 Monkeys idea, once you get enough people feeling good and realizing that everything's going to be okay, all of a sudden everybody feels okay. And then if they want to do a substance, they just do it because they feel good, but there's not the sense of self-medication. And my sense in the drugs and alcohol world that I've perceived up until now is a lot of it is self-medication. And so I feel that I just want to stay in this area for a while and help people, because I feel like my feeling is that we're gonna, I think that if you took everything that I talked about today and deployed it into the addiction space, I think that we would at least cut recidivism in half, but I think we would be more effective than that. And I think that would be amazing. And so then the final thing that I want to tell you, which is totally amazing, is that I had a interview. Somebody came to interview this week, and I said, "What happened? What's happening?" And she goes, "Oh, I listened to your podcast," or she listened to this talk. I don't know how she listened to it. Maybe it was online. And she goes, "I really liked the part about we deserve to be here." And so we did this affirmation. So I want we'll do it again tonight. This would be kind of fun. And so everybody unmute your phone or your computer. And so, and interestingly, I've been doing this, and I do this a lot, but it's interesting to do this. So I'm going to wait until people are unmuted. Awesome. Oh, good. Okay. Well, so everybody say, oh, now this is good. This is always how I do this too. I'm not going to come up with the affirmation. Somebody say something that they feel like really good about, like that we should all say together.
Everything's perfect.
Everything is perfect.
I like that. This is going to be fun.
Oh, this is going to be super fun. So this is going to be super fun, and the reason it's going to be super fun is because
Everything is perfect.
Everything is perfect.
everything is perfect. And what happens is it takes a while to kind of figure it out and realize it. But then what happens is once you realize that whatever happened yesterday was difficult, but it helped us because it informs us. And now we're wiser today. And so as a result of learning from our experience, everything's perfect. I'm more, and I would say I'm like maybe 10 times more inspired than I was before COVID. And I think that what's happened with the difficult problems in society now and what's happened with COVID is a lot of volatility. And what's going to happen out of that volatility is that everything is going to be perfect. And then it's going to be this very, very positive thing. And, it's not, this isn't, like, I remember, oh my God, Marcella, this is so great. So I remember really clearly, my first experience in surgery was with a famous neurosurgeon who the ENT surgeon that I was with said, this is going to be really crazy. And he goes, I'm going to do a skull-based operation for someone, and then it's going to be really crazy. And then he goes, but he goes, just pay attention and then don't say anything. So it's like, okay. And so then they didn't have the instruments. And then all hell broke loose and he started screaming and throwing instruments. And it was like, I'd never seen anything like it. And it was like 100 times worse than anything you've ever seen. It gives me chills thinking about it. And so that was my first day in the operating room at medical school. And it was like, oh my God, it was like, it was as crazy as anything you've ever seen, and somebody's asleep. And so they said, that was crazy, wasn't it? And I remember it was so crazy. And then what happened was, this was a very important person. And so then what happened is they said, oh, you just have to deal with that. And so then what happened is then the idea was just internalize that and accept that. And it is interesting. So I was talking to these guys, and I had one of my favorite people in my practice today came in, who's a very influential person. And so then we started talking about this, and we were talking about the Black Lives Matter movement, which I'm in 100%, 1,000,000% support of. And I said, and my story is kind of trivial. Actually, that's a good one. My story is totally trivial by comparison, but it still makes me feel a little bit emotional. And what happened is that the paradigm that we came to, and the paradigm that we were in for my entire professional career, was just manage bad behavior and internalize it and accept it, and then don't say anything to anyone or you'll be in big trouble. And so then basically I was like very good at that. And so then but what happens is that's catastrophically stressful, and then it leads you to not be empathetic to anyone and to hide because it's like very difficult. What's happening is I feel like our society is waking up to, we all have to basically have better behavior, and we have to create safe workplaces, and we have to create safe places for patients and all of this stuff. And so what I feel like is going to happen from this movement and from everything that's happening is that medicine's going to be better, that we're going to make changes, and that on the other side of this, we're going to look back and we're going to say that was like a pivotal moment, and everything was kind of different afterwards. And what happens is and so anyway, then ironically, I feel the change. I feel a palpable change talking to people, and I feel that that we are going to be better and we're going to do better, and I'm very passionate and excited about that. And so I'm looking forward to what's to come. Anyone can say anything if they want otherwise. But it's awesome. It's going to be awesome, and I just feel I'm excited for the kids going into medical school, because it's interesting to kind of watch them and hear them talk. So, anyways, unmute yourself and let's say it one more time. Everything is perfect.
Everything is perfect.
Everything is perfect.
It's going to be super fun.
Everything is
It's going to
perfect.
be super fun.
Super fun.
Yeah.
It'll be super fun.
And
Yeah.
by the way, it's not going to be perfect. It's perfect right now.
Oh, it's perfect right now. It is perfect. It's kind of interesting. It's perfect. All right. I love you, and thank you for being here.
Thank you, Matt.
Thank you.
Thank you, Matt.
Thank
Thank
you.
you, everybody.
Thank you.
Have a good week.
You can find this Bio Reset podcast and others on iTunes, Spotify, and all other top podcast directories, as well as on bioresetpodcast.com. Make sure to subscribe, and thanks for listening.